Hi, my name is Dr. Maria Szabela. I am from New Jersey. I specialize in HIV, and we are here in New York City for Ask Me Anything About CABENUVA. Come on in.
CABENUVA is for virologically suppressed adults and adolescents with HIV-1 who meet certain requirements. See full indication on screen. It is contraindicated in patients with a previous hypersensitivity reaction to cabotegravir or rilpivirine and in patients receiving the medications listed here. Please watch the entire video for additional important safety information. Please click the link to view the prescribing information for CABENUVA.
Welcome. Let's start with our first question. Should viral blips be a concern? In my experience, no. First, let's align on what a viral blip is. It's a single viral load between 50 and less than 200 copies per ml, with preceding and subsequent values less than 50 copies per ml. Now, in practice, seeing a viral blip is clinically insignificant to me. When I see a blip, I will counsel a patient usually and go through a checklist of investigative potential causes. And usually I repeat their blood work 2 to 3 months to confirm the viral load, and if it's undetectable. Let's get to the second question. Are viral blips more frequent with CABENUVA than daily oral HIV ART? To answer this question, let's first review the clinical trial program for CABENUVA. In ATLAS and FLAIR, it was proven that once-monthly CABENUVA was as effective as a daily oral regimen, and ATLAS 2M demonstrated that every 2-month CABENUVA was as effective as once-monthly CABENUVA. Then came SOLAR, which was the first and only head-to-head trial that compared switching to CABENUVA with continuing daily oral Biktarvy. The adverse events from the pivotal trials are shown on screen. Let's focus on the SOLAR study. SOLAR was the first head-to-head Phase 3b trial of virologically suppressed adult patients on daily oral Biktarvy for at least 6 months. Patients were randomized 2-to-1 to either switch to every 2-month CABENUVA or continue daily oral Biktarvy. Exclusion criteria are shown on screen. SOLAR enrolled a broad range of patients, as seen here on screen. The most common drug-related adverse events in the CABENUVA arm were injection site reactions, or ISRs, consistent with the findings from previous studies. Furthermore, the discontinuation rate due to drug-related adverse events in the CABENUVA arm was 4%, of which 2% of CABENUVA participants discontinued treatment due to injection-related reasons. Please see additional details on screen. Now back to the question. Are viral blips more frequent with CABENUVA than daily oral HIV ART? This brings me to an exploratory analysis of the pivotal studies and SOLAR, where they looked at viral blips, low-level viremia, and isolated suspected virological failure. In the pooled analysis, the frequency of viral blips was similar with CABENUVA at 6% and 7% among oral ARTs. The overall rate of CVFs was less than 1% among those on either CABENUVA or oral ART. As shown here on screen, the presence of blips was not associated with the development of CVF. Of the participants who experienced a previous blip, there was 1 subsequent CVF in those who received oral ART and none in those who received CABENUVA. As stated in the DHHS guidelines, viral blips may occur in successfully treated patients and are not usually predictive of virologic failure. While we haven't formally analyzed data from my practice, I'm not seeing more viral blips with CABENUVA than with any other HIV ART. Here we are with our last and final question. What does CABENUVA mean to you? Now, being in the HIV treatment landscape for the past 23 years of my life, which is half my life, I hold it dear to my heart for the fact that I have seen what treatment means for a patient, for my patient's diagnosis. It means I can actually offer something other than the typical oral regimen that everybody has been taking. Thank you for joining me, and don't forget to check out other Ask Me Anything videos about CABENUVA.
Warnings and precautions. Hypersensitivity reactions. Serious or severe hypersensitivity reactions, including Stevens-Johnson syndrome, toxic epidermal necrolysis, and drug reaction with eosinophilia and systemic symptoms, or DRESS, have been reported with CABENUVA or its components. Some skin reactions were accompanied by symptoms such as fever. Other skin reactions were associated with organ dysfunctions. Oral lead-in may be administered prior to administration of CABENUVA to help identify patients who may be at risk for a hypersensitivity reaction. If a hypersensitivity reaction is suspected, CABENUVA should be discontinued immediately and the patient should be monitored. Post-injection reactions. In clinical trials, serious post-injection reactions, such as those shown here, were reported in less than 1% of subjects within minutes after the injection of rilpivirine. These events may have been a result of accidental IV administration and began to resolve within a few minutes after the injection. It is important to carefully follow the instructions for use and observe patients for approximately 10 minutes after the injection. If a post-injection reaction occurs, monitor and treat as clinically indicated. Hepatotoxicity. Hepatic adverse events have been reported in patients receiving cabotegravir or rilpivirine with or without pre-existing hepatic disease or identifiable risk factors. Patients with underlying liver disease prior to treatment may be at increased risk with CABENUVA. Hepatic monitoring is recommended and discontinue if hepatotoxicity is suspected. Depressive disorders. Depressive disorders have been reported with CABENUVA or the individual components. Promptly evaluate patients with depressive symptoms. Risk of adverse reactions or loss of virologic response due to drug interactions. Adverse reactions or loss of virologic response due to drug interactions with concomitant use of CABENUVA may occur. Use with caution in combination with drugs with a known risk of torsade de pointes. Long-acting properties and potential associated risks with CABENUVA. Residual cabotegravir and rilpivirine concentrations may remain in the systemic circulation for up to 12 months or longer. Non-adherence to injections could lead to loss of virologic response and development of resistance. It is important to initiate a fully suppressive regimen no later than 1 month after the final injection doses of CABENUVA when dosed once monthly, and no later than 2 months after the final injections of CABENUVA when dosed every 2 months. If virologic failure is suspected, switch the patient to an alternative regimen as soon as possible. Adverse reactions. The most common adverse drug reactions were injection site reactions, pyrexia, fatigue, headache, and those listed here. Drug interactions. For important drug interaction information, refer to the full prescribing information for CABENUVA, Vocabria for oral cabotegravir, and Aduran for oral rilpivirine. It is not recommended to co-administer CABENUVA with other antiretrovirals. Drugs that are strong inducers of UGT1A1 or UGT1A9 are expected to decrease the plasma concentrations of cabotegravir. Drugs that induce or inhibit CYP3A may affect the plasma concentrations of rilpivirine. Use in specific populations. Assess the potential risks of using CABENUVA during conception, pregnancy, and while breastfeeding. Please click the link to view the full prescribing information for CABENUVA.